swelling, which is initially was very small in size and gradually increased to the present size, which is around 1 centimeter in the highest diameter. So this case was discussed into the three main components. That is an oral medicine department where they had done the FNAC for the initial which report suggested to be an clusters of an baseloid cells with a round nuclei and the scattered cytoplasm. Many multinucleated giant cell scenes. Background shows an keratin flakes and the calcified materials. So later, they gave the differential diagnosis such as an adrenexal tumor, matricoma, sebaceous cyst, dermoid, epidermoid cyst, foreign body reactions, hematoma, and the basal cell epithelioma. So after the OMR department, it turned to the oral surgery department where the surgical management was done for pilometricoma, where the treatment of the choice was a surgical excision. The external approach was used and the complete excision of the cyst was done and histopathological examination was sent. Later in the oral pathology, where the report has turned to be an where they suggested to be an consisting of an occasional follicles and the solid nest of an baseloid cells with the appropriate keratinization and the predominant areas of an anucleated ghost cells and the keratinization debris are seen. Areas of calcification and the foreign body giant cells noted. Features of the pilometricoma was confirmed. So these are the slides where area of an ghost cells are seen. And this is in a 40x zoom of a ghost cells. And later we'll see abrupted area of keratinization with the ghost cells in a 40x slide. So the discussion of this thing of the pilot is an uncommon lesion that is early confused with the other pathologies. Oral surgeons must be able to recognize this differentiation, this lesion, to be included in the diagnosis hypothesis held in the head and neck lesions. Thank you.
Thank you for the presentation. You may stop sharing the screen.
Thank you.
The next presenter, OMFS PG03. OMFS PG03. Dr. Aishwarya P. Are you there? Okay, then we'll move on to the next presenter, PG04. OMFS PG04. OMFS PG04, kindly start your presentation. Your time starts now. Please put it on slideshow. Presenter PG04, are you ready with the presentation?
Ma'am. Good morning, everyone.
All
Today I am presenting my
presenters kindly note. Please make sure you have adequate network and bandwidth. Okay, we have so many papers in the list, and we can't just waste time on that. So make sure you have adequate bandwidth and adequate network. We are not going to entertain like the network was not working and things like that. Got a calls in between. So kindly make sure you have a good bandwidth and you have a proper network, and your presentation goes smooth, and you are physically present in the hall, or sorry, online present in the hall when you are called for the meeting. Over to the presenter, please.
Presenter on office PG04, kindly share your screen.
No. I am not able to share my screen, ma'am. The topic of efficacy of buffered local anesthesia in periapical infection. The contents are introduction, aim, objective, material method, inclusion criteria, exclusion criteria.
Doctor, excuse me, doctor, you have not yet shared your screen. Your presentation is not visible. Doctor? Dr. Ajay.
Hello.
Dr. Ajay, your presentation
Yes,
is not
sir.
visible. Kindly share your screen. There's a share button down in the toolbar. Just click on that
Yes, sir.
share.
Can you give me 5 minutes?
Next presenter, OMFS PG05. Judge, please not OMFS PG05. Dr. Anita Kurup, are you there? Okay, then we'll move on to the next presenter, OMFS PG06. Okay, OMFS, just please not OMFS PG06 is not presenting. And the last presentation for the first session is OMFS PG07. OMFS PG07. Dr. Ajay, your presentation will be the last. Please be ready with your presentation after this presentation. Stop sharing the screen. OMFS PG06, please share your screen and start your presentation. 07, sorry.
Good morning, everyone. The title of my presentation is Role of Densa Burrs in Ridge Expansion and Osteodensification for Implant Placement in Horizontally Deficient Bone, an in vivo study. Dental implants are currently accepted popular treatment options for rehabilitation of missing teeth. It is essential to have sufficient bone bulk density at the implant site in order to achieve good bone to implant contact, primary stability, which are crucial for osseointegration. Several surgical techniques have been utilized for the reconstruction of deficient alveolar ridges, such as only bone block augmentation, ridge split, ridge expansion, osteotomy. Its procedure has its own merits and demerits. Now, what is osteodensification? It is a novel approach in implant dentistry. The procedure is characterized by low plastic deformation of the bone that is created by rolling and sliding contact using a densifying burr, denser burr that is fluted such that it densifies the bone with minimal heat elevation. Dr. Huwais in 2013 developed a non-extraction technique with specially designed burrs to increase bone density by expanding an osteotomy site. The denser burrs enable bone preservation and condensation through compaction autografting during osteotomy, which enhances implant stability. Contrary to the conventional drills, these drill designs create an environment which increases the primary stability by means of non-subtractive drilling. The science behind osteodensification concept. Osteodensification technique generates a layer of condensed autograft along the surface of the osteotomy site where there is bone paucity. The compacted autologous bone immediately in contact with an endosteal device will have higher degrees of primary stability, which also facilitate osseointegration. In conventional drills, bone remodeling requires more than 3 months to repair the damaged area. Hence, osteodensification technique helps to reduce the healing period. The aim of my study is to assess osteodensification in compromised buccolingual or buccopalatal width of ridges using denser burrs. The source of data is collected from 6 patients reporting to OMFS department in Career Dental College, the patients fulfilling both the inclusion and exclusion criteria. Method. Preliminary treatment planning was done using diagnostic cast on which a diagnostic wax-up was done. Diagnostic intraoral panoramic radiographs and CBCT were taken to evaluate the morphology and the skeletal relationship. The available bone height, weight, and length was calculated. Prior informed consent was obtained from all the patients. After fulfillment of the inclusion criteria, all the patients underwent initial periodontal therapy consisting of motivation, oral hygiene, instructions, and scaling and root planning. Surgical phase. All implants were placed according to a strict surgical protocol following the manufacturer's instructions. Under local anesthesia, crystal incision was given with a full thickness mucoperiosteal flap was raised and the underlying alveolar bone was exposed for osteotomy, or a flapless technique was used. Denser burrs were used to prepare the osteotomy site. By using the pilot drill clockwise at a speed of 800 to 1500 RPM under copious irrigation, drill to the desired depth. After changing the drill motor to reverse counterclockwise direction, osteotomy was prepared by using denser burrs in sequential manner. Implant was inserted into the prepared implant bed. The flaps were approximated and sutured using 3-0 black braided silk. Post-operative intraoral IOPR was taken to assess the implant position. Post-surgical instructions were given. Antibiotics and analgesics prescribed for 3 days. A case is presented where osteotomy was done using denser burrs. Preoperative photos. Insufficient ridge width. Osteotomy site prepared with denser burrs. Placement of implant. Increase ridge width. Results: a halo of compacted bone was seen surrounding the osteotomy site. Increased insertion torque values were noted. The primary implant stability noted immediately after implant placement, 1 month and 3 months later, were significantly on the higher side. Increased density of bone surrounding the implant was noted on CBCT evaluation 1 month and 3 months post-operatively. Discussion: ways demonstrated that osseodensification helped ridge expansion while maintaining alveolar ridge integrity, thereby allowing implant placement in autogenous bone, also achieving adequate primary stability. Osseodensification helped in preserving bone bulk, shortened the waiting period to the restorative phase. Similarly, Tracy et al. And also Berardini et al. In their in vivo study found osseodensification very helpful in ridge expansion. Conclusion: osseodensification utilizing the denser burr technology produces stronger osteotomy for any implant. It preserves the bone to enhance the host. This allows for clinical versatility, which may facilitate enhanced implant stability and efficient expansion of any ridge in either jaw. Thank you.
Thank you. PGMFS 07, kindly stop sharing your screen. OMFS PG 04, Ajay sir, are you ready? Kindly stop sharing your screen. OMFS PG 04, Dr. Ajay, are you there? Dr. Ajay, are you there? Judge, please note that this was the last presentation for the first session. We'll move on to the second session. First presenter, OMFS PG 09. Judge, please note, OMFS PG 09.
Okay, till Dr. Ajay gets the technical issue corrected, we'll move on to the next presenter. Don't worry, ma'am. We'll give Ajay another chance after this presentation. Dr. Aditya, can you call the next presenter? And then we'll get back to Dr. Ajay. See, there seems to be some technical glitches with the presenters. Now, anybody in the hall who have logged in now is interested to present, we'll take up now. If anybody in the hall today who's present now is ready with your presentation, you can kindly share your screen. will and just your ID number before you start. If anyone willing, please share the screen now. There seems to be technical issues with the other people who's presenting. This is one very important reason, like in virtual conferences, make sure you have adequate network support. Anyone in the hall here ready with the presentation? Is there anyone who is ready for a presentation? Because one of the presenter is not so if anybody is interested, I can see somebody's screen, video screen. Are you going to present, Doctor? Dr. Ajay, are you ready with your presentation? I can see your face, Doctor. Dr. Ajay Madhukar Surate.
So I think all of the speeches Dr. Gyaneshwar Ravindra Sukhare.
If anybody is having any technical problem in keeping the back your screen, there's nothing to worry. You can present the way how you are. We have actually recommended to place the or triple OCA conference banner as a background. Don't bother if anybody is there having any technical issues. No problem. Even if you don't keep the background as triple O. Okay. If you're ready with the presentation, Ajay, are you ready? Ajay, I'm waiting for you. Yeah. What is the problem actually you're facing, Dr. Ajay and Dr. Minal? You're not able to share the screen or you're not able to. Ajay, you're doing good. You're doing good, Ajay. Yeah. Oh, yeah. Are you trying to share your screen from the mobile? Please don't do so. Please, presentation has to come from the laptop. I can see that you have shared the mobile. Thank you. Dr. Aditya, has anyone else?
Sir, Dr. Dhyaneshwar arranged all of the PG 10 is ready, I think so.
Okay, so let Ajay get ready with the presentation. Let us take on with Dr. Rajeshwari, the next presenter. If she's ready, let him share. And Dr. Ajay, can you start? Button down. There's a stop share. Just click on that. We'll come back to you. Don't worry. Okay, Ajay, we'll come back to you. Please click on down share or stop share. Ragesh is coming.
Okay.
We'll move on to the next presenter. The next presenter, OMFS PG10. OMFS PG10.
Call out the names also,
You
please.
may start presenting.
Hello. Hello.
Then I think OMFS PG10 is ready. Kindly share your screen.
Yeah.
Hello. 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 Hello.
You may start presenting now.
Hello. Can you hear me?
Yes, we can hear you, doctor. Please proceed.
Sir, I am going to present a review or literature about the patient-specific maxillofacial implant.
Dhaneshwar, kindly share your screen. We can't see your screen. Click on the share
sir.
screen button.
Yes, sir.
മറ്റേ പുള്ളി സ്ക്രീൻ എല്ലാം കട്ട് ചെയ്തായിരുന്നോ? നിങ്ങൾ തമ്മിൽ കോറിലേഷൻ വേണം. വിളിച്ചാളെ പിന്നെ വിളിക്കണ്ട.
Message. Give me 5 minutes.
Dr. Dhyaneshwar, are you ready? Dr. Dhyaneshwar, are you ready? We'll wait 5 minutes. Is there any presenter who is ready with the presentation? Anyone who is ready with the presentation? OMFS PG 28, Dr. Samruddhi Dhanave. Are you ready?
Hello, ma'am.
Please share your screen if you're ready.
Yeah, just a minute. I'm trying to share.
Dr. Samruddhi, are you ready?
Yeah, just a minute. I'm trying to share my. Tell me the meeting ID. Just 2 minutes. I'm just trying to share my slide. Just 2 minutes.
Okay, we'll give you 2 minutes. Please read it first.
Meeting ID. Meeting ID. Password. Conference.
Dr. Samriddhi, are you ready? If you are ready, please share your screen.
There is there is error to support the document. Please continue with another presenter. I'll come within.
Dr. Samruddhi, we'll come to you later. We'll move on to the next presentation. Dr. Minal. Hello.
Hello, good morning, ma'am.
It's not ID OMF PG 17. OMF plus PG 17.
Hello. Hello, am I audible, ma'am?
It's your
So I'll start with my presentation. Today's presentation. The title of my manuscript is Comparing the Anesthetic Efficacy of Single Buccal Infiltration of 4% Attecan versus buccal and parietal infiltration with 2% lignocaine during bilateral extraction of maxillary
Can you put this on slideshow?
दिख रहे हैं क्या आगे? नहीं, मैं आगे नेटवर्क का इशू है फिर. Hello.
Please put it on slideshow and also turn on your video.
Okay, okay, ma'am. Just is it visible now? Is it visible now, ma'am?
Yeah, it's visible, but please put it on slideshow.
I have already put it on. Okay. Is it visible now, ma'am?
Yeah, it's visible, but put it on slideshow from the beginning. Top left corner, you can see from the beginning that. Click on that.
हमारा फोन दाखव. माझं चांगलं रेंज आहे.
Dr. Minal, are you there? Dr. Minal? Dr. Minal, are you ready? Please share your screen.
Hello. Able to I have ordered the
Dr. Minal, are you ready?
Yes, ma'am.
Okay, you may start presenting. Jets, please note. Next presenter, OMFS PG 17, Dr. Minal. Your time starts now.
Good morning, everyone. Today I'm presenting a paper on comparing the anesthetic efficacy of single buccal infiltration of a 4% artican versus buccal and palatal infiltration with a 2% lidocaine during bilateral extraction of a maxillary first permanent premolars for orthodontic reason. I am covering so the introduction, local anesthetic from the mainstay of pain control technique in dentistry. Since first synthesized local anesthetic was the procaine in 1940.